Ladies and gentlemen, welcome to the role of acute care in the opioid epidemic. Your host for today, Karen Herring. You may now begin.
Hello, everyone. This is Karen Herring with MPRO, Michigan's quality improvement organization that is part of the Lake Superior Quality Innovation Network, or Lake Superior QUIN. Lake Superior QUIN represents Minnesota, Michigan, and Wisconsin under the Centers for Medicare and Medicaid Services Quality Improvement Organization program. This webinar is presented in a collaborative effort between the Lake Superior QUIN and the Great Plains QUIN, which includes the states of North Dakota, South Dakota, Nebraska, and Kansas. It is no secret that nationally we are experiencing an epidemic of opioid misuse and abuse. Recent studies suggest that new persistent opioid use after surgery is common, with approximately 6 to 10% of patients who were not taking opioids before surgery continuing to use opioids more than 3 months after surgery, depending on the procedure. In this webinar, we will learn about a preventative approach for the state of Michigan, which ensures that post-operative patients are receiving appropriate pain management and palliative care while protecting patients and communities from the harmful effects of excess prescription opioids. This webinar is part 1 of the series on the opioid epidemic. Today's educational session is entitled, The Role of Acute Care in the Opioid Epidemic. Before I introduce our speaker, I'll mention that all lines are muted during this webinar. However, after the presentation, we will have a time for questions and answers, so please make a note of any questions that may come up as you listen, or you may use the chat feature, which is on the right side of your screen. Now I'd like to introduce our speaker, Dr. Englesby. Dr. Michael Englesby co-directs the Michigan Opioid Prescription Engagement Network, or Michigan OPEN, an initiative that seeks to transform pain management and curb opioid abuse in the state of Michigan. Based at the University of Michigan Medical School and Institute for Healthcare Policy and Innovation, MOPEN is a 5-year initiative funded by the Michigan Department of Health and Human Services. Dr. Englesby is a Darling Professor of Surgery in the section of Transplantation Surgery at the University of Michigan. His research is concerned with the relationship between the cost and quality of surgical care. He also specifically focuses on patient frailty, morphomics, surgical outcomes, and post-operative opioid utilization. Dr. Englesby earned his undergraduate degree in biology at Yale University and his medical degree at Robert Wood Johnson Medical School. He completed his general surgery residency training and fellowship in multi-organ transplantation at the University of Michigan. Dr. Englesby, I will now turn it over to you.
Great, thank you very much. It's an honor to speak. I will try to not make this too boring. A couple things. One is I am not an expert on chronic pain, and I am humbly kind of proposing an idea for what we're doing in Michigan to try to combat this epidemic. But this epidemic, as we know, is so very complicated. This is just kind of one approach that I think that so far has been impactful. Nonetheless, I don't mean to oversimplify the complexity of every patient's needs in this process. And then I guess I'll tell the story as to why I got interested in this problem. So I am a transplant surgeon, and in Michigan we initiated a process where before every donor operation we would pause and for 30 seconds and give thanks to the donor right before the operation. And you basically would be standing there in the operating room, staring at the donor about to operate on them, and kind of left with your thoughts. And after we started doing this, I noticed more and more that medical students or residents, particularly medical students, would ask me the story of this donor and how they got where they were. And I would kind of tell them the tales that I knew, not usually knowing many. And it became clear to me through these discussions and through the questions of these young people that were kind of seeing transplantation for the first time that we had an ongoing public health problem that really had not been talked about much, and that was the opioid epidemic and the associated overdose. In Michigan, the percent of organ donors from overdose has gone up more than tenfold. And in the United States, last year we did more transplants than ever before, despite the fact that every other aspect of our lives has gotten safer, including car crashes or kind of violence. This is largely fueled or almost completely fueled by overdose deaths and the opioid epidemic. So it's a good it's a busy time to be a transplant surgeon, but certainly this is kind of not the outcome that any of us would want. So if you can look at my slide, the number here states 115 Americans die every day from opioid overdose. 2 years ago, that number was about 70. Last year, it was about 90. So it continues to grow, and I anticipate it'll grow. It will continue to grow over the next 2 to 3 years in the United States. That having been said, a lot of progress is being made on the opioid epidemic, and there is reason to be optimistic. This slide point out one piece of data. Nearly half of men aged 25 to 54 who are not in the workforce take prescription opioids. We as physicians, and I take the context of a physician and how I as a physician have contributed to this epidemic, we as physicians have significantly contributed to this public health problem, and it's been devastating throughout our communities and then for the lives of many of the patients we've attempted to care for. And the implications when we go out and talk, one group of stakeholders that is particularly interested in what we have to say are employers. They're struggling to hire people. Employment is the lowest it's been in recent history, and in part because so many people are out of the workforce because of chronic pain, chronic opioid use, misuse, and addiction. So who overdoses? It really goes throughout every socio-demographic group in our society. It's potentially more focused in all parts and in the Midwest. Kentucky, West Virginia, New Hampshire have been particularly blighted by overdose. But in Michigan, for example, we're approximately about the 10th, somewhere between the 10th and 15th highest rate of overdose in the United States. But no state has been untouched, and overdose rates have gone up really across the entire country. So the general crux of my talk is the fact that we are trying to take a strategy around preventing chronic opioid use and abuse. So lots of current resources are well-intended, and appropriate resources are focusing on the chronic opioid user, trying to wean them off opioids, and the implications of opioid diversion in their community, and the implications of how those contribute to the opioid epidemic. But our focus has primarily been on acting upon healthy patients who are not on opioids, and trying to prevent them from progressing to new chronic opioid use, abuse, and addiction. So we were trying to prevent new opioid use. And we have surgery in here, but basically you can insert there any acute care. So whether you go see your emergency room physician, your primary care provider, your dentist, or your surgeon, if you have an acute health problem, how does that interaction with the healthcare system potentially lead to new use and abuse? And the statistics around how that happens are pretty humbling. The vast majority of people who do use opioids every day, including people who use heroin, their first interaction or their first exposure to opioids was through a prescription from a physician. So the number specifically is approximately 85 to 90% of heroin users, first time they used opioids was from a prescription from a dentist or a physician. So the role of the nurse and the physician who care for patients when they are in pain is absolutely critical as we try to combat this opioid epidemic. So in short, we as surgeons, or I as a surgeon, have prescribed too many opioids. And I think that is slowly in the process of changing. I'll talk a little bit about that. I'll show you some data. I'll try to go through it quickly. But this slide shows the amount of opioids prescribed after surgery and how the fact is not associated with patient satisfaction. And this is just one reference of some of the work that we've done. And this is kind of hospital level data. So if you stratify hospitals by hospitals that write for few prescription opioids or have low opioids are given after kind of care within the hospital versus hospitals that write for a lot of opioids, there's really no relationship to that HCAHPS score around pain. And we've looked at this in many different ways. HCAHPS score obviously is kind of a blunt measure, but we look at really at the patient level also. We said, you're given 5 pills, you're given 50 pills. How is your pain fare? And there's it comes down to care and the discussions and education, how well we listen to our patients. It really doesn't come down to how many opioids we write for. We as surgeons, though, I think have continued to escalate how many pills we write for various reasons. And one of them is wanting to satisfy our patients. The other is concern about refills. So this slide shows the relationship between number of pills written for. You can see down here it ranges from 6 to greater than 60 pills after normal surgical care. This is, I think, a state of Michigan sample of people who have had kind of elective general surgery, healthy people, opioid naive. And this slide shows the probability of them calling for a refill. And you can see there's really no relationship between whether you give them 8 pills or you give them 60 pills. About 7% of patients are going to call for a refill. And those 7% of patients are particularly vulnerable groups that need special consideration. Because they may not be using the opioids for kind of surgical pain. They may be using them for other indications. But the point being is writing for more pills does not save work from your office and reduce the number of prescriptions. The number of refills, which certainly are onerous on practicing and physicians to manage. So I think this is my most important data slide. I'm not going to show much more data, but this one is worth paying attention to. We've written many papers on this topic over the last year or two, and this is by far our best paper. My partner, Chad Brummett, wrote this paper, and it looked at an actual sample of patients who had elective surgery for things like colectomy, gallbladder removal, hernia, thyroidectomy. That's a thyroid, by the way, in the middle. And looked at patients who are opioid naive, who then had successful surgery with no complications, and looked at them many months later and asked the question, what percent of these opioid naive patients are now new chronic opioid users? And that number is 6%. It parallels, as you can recall, about the number of people who call back for refills. And as we continue to look at different types of operations, we were struck by this number. We then looked at other. So this is total hip and total knee arthroplasty. The number is 8%. 13% for patients having hand surgery. Among pediatric patients, it's primarily adolescents having discretionary elective surgery. It's a very distressing number of 5%. Patients having cancer surgery, so kind of bigger operations for things like lung cancer or pancreatic cancer. About 10% of those patients become new chronic opioid users. And for breast cancer surgery, it's up to 19%. So as you can see here, when our patients come to us and they're not on opioids, as surgeons, many of them leave our care now taking opioids every day and transitioning their care to other providers, particularly the primary care provider, who are essentially kind of stuck with patients who need daily prescriptions or need refills of prescriptions. And many of these patients continue to use, and then as basically physicians essentially don't write for them anymore, can cause problems with misuse and use of street drugs and other resources. And I'll talk at the end of the talk about the reservoir of pills within our communities. Now I'm going to tell a little story of gallbladder surgery at the University of Michigan. So I am obviously a surgeon. I don't really take out gallbladders, but I know people who do. I think laparoscopic cholecystectomy, which is gallbladder removal, is a very simple operation that's commonly done, or most commonly done, as an outpatient, and it's frequently done on healthy people. So we just kind of thought about, or we tried to figure out what we do at our very good hospital in Ann Arbor to see, how our prescribing potentially impacting our patients. So we looked at all the patients who had an elective gallbladder removal who were not on opioids, and we asked the question, how many pills do we write for? And at our institution, physician assistants, or primarily surgical house officers, write postoperative prescription. It ranged from 9 pills of what we call Norco up to 120 pills. So a lot of variation, kind of essentially randomness. Then we asked the question, what's the average, so to speak, for most of these prescriptions? And they're in this range. I think the average was about 45 pills. Then we called all the patients and said, how many pills did you take? And as you can see here, there's a huge mismatch between in the red where we write for opioids and then how many pills patients took. And a lot of patients didn't take any pills. And I think, many of you, if anyone's still paying attention and if anyone's ever had a procedure, the majority of patients say, I hardly took any. I took 1 or 2 the night after surgery. Then why the heck are we as surgeons writing for 40 pills? It just doesn't make sense. There's a big mismatch between consumption and how much we write. So now the question is, so what are we going to do about it? Well, for gallbladder surgery at the University of Michigan, this is all done by a medical student, by the way. He said, why don't we just write for 15 pills? And all the surgeons like, that's a great idea. And a lot of hard work is done. Anyone who tries to change care in a complex health system understands how hard it is. And it turns out gallbladder surgery at the University of Michigan, which are about the healthiest people we take care of, 17 people give them information or education about their outpatient surgical care. So we had to talk to 17 people, or different types of stakeholders. So a lot of hard work was done, but basically we said, all right, we're going to get 15 pills. And what we noticed is that patients didn't call more frequently for refills. They did not report more pain, even though we wrote for only about a third as many pills, and patients took fewer pills. And I think that's a really important point. A clear relationship that's now seen in 3 or 4 different types of surgery, where the more pills you write for, the more pills people take. And I have a personal anecdote. When my sister had surgery a couple years ago, my mother was dutifully helping take care of her. I came to visit, and I noticed that my 6'2" sister was essentially nearly comatose for the first couple of days after surgery. Didn't really think about it. Other than that, I was kind of glad that she was doing okay. In retrospect, I realized that my mother was giving her two pain pills every 6 hours around the clock, whether she was in pain or not. And I think that is more and more common. If you take many patients take the pills the doctors give them, and that can lead to some significant kind of deleterious implications. Just within our gallbladder patients at the University of Michigan, over about a year, we basically reduced by 35 pills per patient over 170 patients. So that's a lot of pills that we kept out of our community. And we have continued this work, and I'll talk a little about how we've taken this little project done by a medical student and tried to expand it across this really unique platform we have in Michigan to change. And that includes, or that is highlighted by what we call our Blue Cross Quality Collaborative. So across different surgical specialties, there are communities of physicians, anesthesiologists, and surgeons across all the hospitals in Michigan that work together to drive change. It's physician-led. I think I feel very strongly that payers and hospitals can only do so much to really transform care. Ultimately, care has to be changed by nurses and doctors at the bedside. And this group is uniquely well suited to drive this change. I have the honor to serve as the director of the Michigan Surgical Quality Collaborative, and we basically partnered with other stakeholders to try to understand whether we can make some more progress in the state of Michigan. And we've really had a great experience with various partners, and I'll particularly call out 2. One is the Michigan Department of Health and Human Services. They have really made us focus on our most at-risk populations in the state of Michigan. And they've really facilitated our opportunities to really make Michigan a better place for acute care. And then equally important is the Blue Cross and Blue Shield of Michigan. They fund this entire platform for change. Michigan is a remarkable place to get surgical care, and mostly because of the visionary kind of platform that Blue Cross and Blue Shield has established. And it kind of makes it relatively easy to do things like change opioid prescribing practices across an entire state in a relatively quick, short period of time. And other partners include the trauma surgeons, the orthopedic surgeons, the spine surgeons, and among others, the anesthesiologists. So kind of what we have done is we have data feeds from numerous hospitals in the state, and we basically ask patients how their pain control is. We ask patients how many pills they took, and then we know how many they are written for. And every 3 months, we look at the data and we expand the list of how many pills should be written for common surgical procedures, and make specific recommendations, prescribing recommendations. We do this throughout our collaborative. And as you can see here, these are the current recommendations. They continue to drop because patients are taking fewer pills, physicians are writing for fewer pills, and pain care is actually getting better. So it's exciting. We released these in October. We started working on this last January. We've already noticed that patients are taking fewer pills and doctors are writing for fewer. And we anticipate that number will continue to decline significantly. And we aspire, or we plan to expand this list to cover pretty much every common operation done in the state of Michigan. These recommendations are obviously available to anyone who has interest. I'll point out the fact these are data-driven. These are real numbers that basically try to right-size this prescribing so that patients get the prescriptions that they need and no additional pills. So another really important point and the perfect segue is what happens to all of those excess pills. I'm a surgeon. I take out a lot of kidneys for transplant. My patients go home on 50 pills. They probably take 5. What happens to all those excess pills? So nationally, and this is a group from Dartmouth, noted that only about 72% of pills are left over. And think about it, if you've ever had wisdom tooth removal or any other procedure, all the leftover pills you have. And we've seen a similar number, right around 70% across 5 or 6 different groups of patients in different procedures. Just to put that in context, in Michigan, we do 1.8 million operations a year with 33 extra pills on average in Michigan. A lot of extra pills, 62 million unused pills per year. And just, it's the University of Michigan, so of course I have to show our athletic facilities. If you take all those extra pills in Michigan and you pour them on our football field, you can fill the thing up with Vicodin, and then also fill halfway, 3/4 of our hockey rink up. So a lot of excess pills. What are the implications of those excess pills? So my partner gave a talk to a local high school in Ann Arbor, great high school, and asked the students, they're probably 15 or 16 years old, how many of you can get your hands on opioids in the next hour, and pretty much everyone raised their hands. So these pills are within our communities. My other partner, Jen Walge, plastic surgeon, said innumerable patients tell her they don't want to pay the copay for the prescription, they'll just get the pills within the community. They'll either pay for them, within their community or just get them from family or friends. There is a remarkable number of excess opioid pills in our communities. And our approach to try to combat that to a certain degree is opioid kickbacks. And I think I'm sitting actually in a great hospital right now in Michigan Henry Ford Hospital. I'm literally looking at the pharmacy, and right out the door of the pharmacy is a pill disposal. I think the complexity about putting these in your clinics is significant. But I think that's a direction that we, at least as surgeons in big hospitals, need to go, where you come back in for your post-op visit, you bring your pills. In Michigan, for the last 2 years, we've been doing what we call opioid take-back drives, and our most recent one was in September 2017. We were at 9 sites, and we got 900 pounds of pills. The majority of these were from surgical care. They're leftover pills. The leftover pills, if you have them in your home, you need to get them out of there. They are the most common reason for home break-in in the United States. We having another opioid take-back event. We aspire to have 30 sites this spring. I think it's been about 6 weeks, using this remarkable platform that is facilitated by the Michigan Department of Health and Human Services and Blue Cross and Blue Shield of Michigan, and also resources that we have. We are able to essentially coach sites on how to do a take-back and potentially even provide funding to facilitate that. So we are the Michigan Opioid Prescribing and Engagement Network. We have various strategies to try to positively impact this significant public health problem. And some of the interventions are kind of standard, talking to our policymakers, doing lots of education, focusing on payment reform, and Blue Cross and Blue Shield of Michigan has been a great partner to potentially facilitate and incentivize opioid minimization surgical care. And then focusing at at-risk populations, and also doing some really innovative things around the arts and humanities to try to educate our young people. So I just have a couple more slides and I'm stop talking. We have significant resources that we can provide to anyone who would like to use them. And this is just from our website. Bunch of opioid informational brochures for physicians, for nurses, for patients, and you can actually put your institutional or your stakeholder information in there, and we can send you, or even send us your brand, and we'll put it on there for you. There's no branding specific to the University of Michigan on here. They're certainly available for anyone, and they're well done. They're vetted by clinical experts. They've been done by kind of patient education expertise and been gone through multiple iterations, and they are now frequently used within the state. They talk a lot about opioid safety and care, I think, and talk a lot about opioid disposal. lots of hospitals are providing kind of disposable bags at the time prescription, which is a step forward. Lots of hospitals are working towards opioid disposal within their institutions. I think all of these things are a step in the right direction. So I think this might be just about my final slide. We at the Opioid Prescribing Engagement Network are coming out with recommendations based on consumption for opioid prescribing. Our hope is to reduce opioid prescribing and these reductions in opioid, and this will lead to reduced consumption among patients. And I think this will be an iterative cycle. I sincerely think over the next 5 years, many surgical procedures will be done without opioids. I think that's the direction momentum is going, and I think that's a direction that has to be done by nurses and physicians at the bedside. There's really people who focus on kind of systems and quality. They can't really have that insight to make sure that we're taking care of the patient, providing appropriate and excellent care, including pain care, but at the same time also not harming our patients with opioids. I want to make it clear that opioids are not bad for everyone, and just like any patient, they're complex, and everything has to be managed on a case-by-case basis. But I think for many patients, there's a lot of new opportunities that we hope to identify to improve their care. I think some patients really do not do well with opioids, and they have some of them have some risk factors that you can identify. A lot of our work, particularly by Chad Brum or my partners, is to identify these people in a more specific way for people who essentially should hopefully will not be given opioids because of the potential implications and risks for future use, misuse, and addiction. But that is, I think, a ways away. Right now, I think less opioids is a movement, is moving in the right direction. So this is our team. We are here. We are a resource funded by generously by multiple stakeholders, and we are excited to help in any way that we can. I think there's some background noise. I do apologize. I think it might be me. I am sorry. I am a transplant surgeon, and I can't really control my schedule, so I'm sitting on the ground in the lobby of a very good hospital trying to. So I hope hopefully this has been useful to folks. But I do apologize. I'm on my cell phone. I think that could be some of the problem. So anyway, that's my last slide. I guess I see some questions coming up here. I'm not sure exactly what we'll do next.
Thank you very much, Dr. Englesby. We now have time for questions or comments for Dr. Englesby. Operator, will you please remind our participants how to get into the queue for questions or comments?
Ladies and gentlemen, if you have a question at this time, please press the number 1 key on your telephone keypad. If you have a question at this time, please press the number 1 key on your telephone keypad. We are waiting for callers to join the queue.
Great. There's a couple questions that have come up. Can I answer them?
Certainly.
Great. Question from Mary Martin. Is there data for spine surgery? I think spine surgery is particularly challenging for lots of reasons. We have focused on easy things like lap pulley. We are actively collecting data to release recommendations on total hip and total knee arthroplasty, also a complex group of patients, and it'll be more complicated than just right for this amount. There'll be a whole care pathway that we would recommend that would be endorsed by the joint surgeons in Michigan. As far as spine surgery, we were working in that direction also, and lots of innovative stuff has been done in the state, but we do not have enough data to really make a specific recommendation at this time. Another question, can we have the opioid information again that we can get our facility name for our patients? Yes. They don't really let me manage the details in the group, but if you Google Michigan Opioid Prescribing and Engagement Network, we do have a website. I am sure through this webinar, all these slides will be made available. And then I guess finally, you could just email me directly. My email is Englesby, spelling is ENGLESBE @umich.edu, and I'm happy to make sure you get in the hands of the good people who do that work with us. How is the data collected? So through these Blue Cross continuous quality improvement communities that we have in Michigan, we have data collections set up across the majority of the hospitals in the state across various specialties. And we've leveraged that remarkable platform to collect the patient-reported outcomes and to collect the data on how many pills are written for. It is a ton of work, and that's why we would be very excited for anyone and everyone to share these recommendations out of our state. I think we do have this somewhat of a unique platform to try to align how many what the physician is writing for with what the patient is consuming, and then most importantly, how the patient is doing. So is your pain care adequate? Are we taking good enough care for you? Because at some point, patients are not going to get opioids who really need them, and we're actually trying to avoid that. I'm sure that is probably already happening. Hopefully not very much, but I think that's why this is a complex problem, and we caregivers need to be at the table to try to fix it. In your opinion, what is the role of pain assessment in opioid prescribing? So we are starting pain planning perioperatively, and once again, I have to limit my view to this acute pain environment. I'm not an expert in chronic pain. I'm not a primary care provider. I'm not a pain physician. My partner, Chad Grummett, is, and he can answer a lot of these questions, kind of more complex questions better than I can. But that having been said, we focus a lot on expectation management. So, for example, if you're having your gallbladder removed, the average patient takes 3 pills. We expect you to take about 3. We will give you this number. This is what normal pain feels like. Surgery hurts. It's going to hurt for a day or 2. It should slowly be getting better. And we're going to put you on around-the-clock Tylenol and Motrin because that may work just as well as those opioids. Not every patient can get Motrin. Most patients can get, NSAIDs in the acute setting. In the chronic pain, once again, more complicated situation. We'll defer comment on that. How's the data collected? I talked about that. How will your program be affected by state of Michigan prescribing limitations? The limitations are still a lot of opioids. So this is kind of where I think it is hard for policymakers and hospitals to really impact this the way I think bedside caregivers can. The limitations are essentially a little bit of a moving target, but basically limited to a 7-day supply. Realistically, if you're having a normal post-operative course, you don't need 7 days of pills. And I think that is very clear. If you give someone 7 days of pills, you're filling up a bottle, and that's what they're already getting. So I think in the acute setting, for the majority of patients, the limitation will not affect prescribing. That having been said, in some types of procedures that I'm not expert in, spine surgery comes to mind. Many more pills are given for a longer period of time, and we're working to try to kind of understand how we can situation.
Hello, this is the conference operator. We do have a couple of questions. My first question comes from Cheryl Wilcox. Please go ahead.
I actually typed my question in as well, but is there anything being considered for new pain medication, any other types of medications other than your traditional over-the-counter?
Yeah, great question. So are there any considerations for kind of alternative pain medications? I will play somewhat dumb here. I don't know. There are lots of people who would have various answers to that. And I think there's a lot of opportunity. Opioids are still the cornerstone for pain, post-operative pain care. But I think that's going to change. I do think Tylenol and NSAIDs are going to become more primary. So, for example, the majority of people who get a wisdom teeth removal are given opioids, and there's good data showing that patients do just as well with NSAIDs and Tylenol. Anecdotally, patients who have lap chorea at the University of Michigan now, some of them are put on a protocol where they do not get opioids except for post-op day 1, and they're given around-the-clock Tylenol and Motrin. That having been said, there are lots of potential regional anesthetic, regional kind of strategies at the time of surgery to try to minimize pain. I'm not an anesthesiologist, but certainly anesthesiologists can talk about that. There's other therapies such as deep breathing, meditation, the things that can be significantly or can be very effective. Patients expect to be given a pill and not to have pain. I think more importantly, and most importantly for my talk, I think those expectations need to be changed. I'll say I think it's changing. I think patients are going to fix this problem more than any of us. I'm having patients, I'm a transplant surgeon, and I generally see people who are pretty sick and have a lot of health problems. But more and more patients are basically refusing opioids, or at least kind of asking questions about the safety of those opioids, which is certainly, I think, a step in the right direction.
Our next question comes from Mary Jo Vernon. Please go ahead.
Oh, hi. I already got my question answered, but I did want to suggest I work at Huron Valley, Sinai, and Hummerson. We use a lot of gabapentin pre-op and post-op, and it has reduced our opiate use significantly.
Yeah, so we do that too at our institution for certain lines of care. I don't know the data. Dr. Brummett, my partner, would kind of know the data on that, but that's good to hear. And in our current kind of protocols that we suggest, we haven't incorporated that. I think this problem will be fixed at the bedside by caregivers. So I certainly appreciate your comment.
Our next question comes from Julie. Please go ahead.
Hi, thank you very much. I appreciate the information about the things that you're sharing with patients ahead of time regarding expectation management. And I've seen the open brochure, which I think is great. I haven't looked at it recently, but what I'm wondering, because we're beginning to work on this specific area in my health system, if there's a document with talking points for providers that are sharing the education with patients prior to surgery, if you have some type of document that you share with providers that you would be willing to share with others.
Yeah, great question. The answer is, of course, we'll share it. I don't know if we do. We have several communications and clinical experts who do develop these educational materials. And if we don't have it, I bet we would create it for you. If you could just contact me or contact the team, and they may be able to point you in the right direction regarding those materials. So sorry not to answer your question very well.
No, thank you. I will reach out via email. Thank you very much.
Great.
Ladies and gentlemen, if you have a question at this time, please press the number 1 key. If you have a question at this time, please press the number 1 key. Our next question comes from Gladys Winters. Please go ahead. Ms. Winters, your line is now live.
All right, how about I try to...
I'm sorry, I was on mute. Yes, I wanted to ask you about rotator cuff surgery. What you think that would entail as far as post-op regimen of the shoulder?
Yeah, great question about rotator cuff surgery. I'm sorry, I'm not doing a very good job answering these questions, but I'm trying to remain a humble steward of this really important topic. And I would probably turf that one to one of the orthopedic surgeons, or to my partner, Chad Brummett, kind of understands a lot of these kind of specific recommendations that are specific to procedures. We have been focusing on the easy stuff, admittedly, bits and piece removal, discretionary surgical care, and avoiding a lot of orthopedic and spine surgery simply because of the complexity of care. A lot of patients come in with pain issues before surgery, and the post-procedural physical therapy that is necessary. And I'm a transplant surgeon. I can't say I really understand that. So I'm essentially not going to answer your question. I apologize for my lack of expertise.
Oh, no, that's fine. Thank you, Dr. Finkelstein.
It looks like someone on the chat, actually, Monica, who is the better part of my brain, kind of put our email, which is michiganopen@umich.edu. It's on the chat if you're looking. I think she just sent it to me. So I will actually post that on the chat. Isn't technology amazing? And you can call us, and our team will get back to you right away. There's a great question from Denise I want to respond to, and that question is, let me see if I can chat that. There we go. I just put the email on the chat. The question from Denise, and I'll read it, is, with cardiac surgery, is very limited use of NSAIDs to do black box warning for patients with cardiovascular disease, potential increase in MIs and stroke. do you take that to each patient using more NSAIDs? Yeah, great question. So I'm a liver transplant surgeon. I do kidney transplants, and renal failure is a significant concern for anyone who has cardiac vascular transplant surgery. And it really does impact outcome and impacts mortality. So the use of NSAIDs in patients with cardiovascular comorbidity is and should be limited. And I don't have a great answer other than opioids still, for those patients, should be and are the cornerstone of pain care in the outpatient setting. And I think all of the educational pieces still need to be in place. And I think fewer opioids will probably be appropriate for the majority of those patients. But I think your point is well taken. And that's why, it's really hard for payers, policymakers, and hospitals to kind of hit this problem, because every patient is a different journey, and some of those are things that clinicians really need to kind of drive. So it's a great question, though, Denise. Thank you. I don't see you have any access to the PowerPoint slides. I'll defer that to the team, or you can just email that, and we'll send the PowerPoint slides to you. There's nothing in there that's secret. So I don't have any other questions on the chat.
We do have one more question from Michael. Please go ahead.
This is Dr. Gross. How are you? I was wondering, on your liver transplants, do your anesthesiologists routinely use thoracic epidurals, and do you also have anesthesiologists doing tap blocks with Exparel?
Yeah, great question. So in our liver transplant patients, no, we don't do that. They frequently aren't candidates for a lot of these kind of effective kind of bedside procedures because they have thrombocytopenia. And they're just kind of too sick for anything other than a liver transplant. But the question was about tap blocks. So, and actually our pain team actually just suggested something like a lumbar staple or some kind of other block potentially for for some patients. And the patients that we do a lot of regional anesthesia for are kidney donors. And we do tap blocks kind of after the induction of general anesthetic. And they're on opioid-sparing kind of protocol. It very much parallels a lot of these fast-track surgical pathways that really have started in colorectal surgery. And I think, we incorporate things like prehabilitation, which is perioperative optimization, or essentially pre-op physical training with pain planning, expectation management, and then pain optimization. I think a lot of this stuff needs to be done preoperatively. That having been said, to do it well, you need to partner with pain docs and anesthesiologists. And my primary partner here are two people. One's a hand surgeon, the other one is an anesthesiologist. And as far as Exparel, I don't know. I don't think, I know some people feel strongly that it is impactful. I don't know the data well enough to comment. But I guess in summary, partnership is absolutely key to optimize the care of these patients. Because there are patients, and more, 10+% are come in with chronic pain, chronic complex pain needs, and caring for them as a surgeon can be challenging, and they kind of deserve better than just having someone like me taking care of them and their pain postoperatively. So anesthesia teams and pain teams can be absolutely critical. And once you start this, and this is kind of how I got going on this to a certain degree, then a lot of great ideas kind of start to flow between nurses and pain specialists and the surgeons and how we can optimize care of all of our patients.
Thank you.
Great question. I have another one here. You mentioned PCPs are stuck when patients request opioids after surgery. What resources or strategies do you offer primary care providers in dealing with requests for ongoing opioids after acute injury or surgery? This is a great question, and we struggle with this mightily. When I give this talk to primary care providers, they always ask this question, and it frequently sounds like this. The spine surgeon, the orthopedic surgeon basically got them on these opioids and now refuses to refill them, and they come back to see me, and I am stuck. And I can't say I have a great answer. We are working to intentionally kind of work on these handoffs, these transitions of care. But I think as much as it's a problem in the domain of care, it is also a problem here. Blue Cross has some really innovative ideas on how to incentivize these transitions of care. But I think the onus is still going to be on the acute provider, the surgeon, and to essentially not let this happen. But Tracy, I think your question is great. We've only been cranking on this for a year and a half, and our strategy has been do the easy stuff first. I think two big domains where we have not made enough progress are the complex patients, particularly, patients like spine patients, and two is this transition of care. We're working hard on it, talking with our PCPs frequently, and hope to have some resources in the next 6 months. We'll keep you updated. And this Monica has chimed in here. So we were working with transitions because Monica leads these efforts for our group. On the chat, you can kind of see what she has to say. We have a meeting on April 20th. You reach out to that email. Oh, that's only for me. Reach out to that email. We can give you those details. But I can't say we have any brilliance around that tough transition of care. I think if it's a frequent problem, this is usually my answer to primary care providers. Primary care providers underestimate the impact, how much surgeons care about them with respect to referrals. Don't refer your patients to those surgeons because it's not good care. Any other questions?
There are no further questions at this time.
Great. I apologize if there's any noise. Like you, I live a hectic life. I'm glad that technology seemed to work very well. I really appreciate the opportunity to speak, and I apologize for my somewhat dodging a lot of the questions. Just out of sincerity, I don't know the answer. And we would love to hear from any of you about ideas that you have in your health systems, and we have a unique platform to try to push change, and we're also very excited and with ample resources to share our work, our communications, and our expertise with you. So.
This concludes the educational session. Thank you again, Dr. Englesby, for speaking with us today. Before you close out, please complete the survey that will pop up. We appreciate your valuable feedback on today's session. This webinar was recorded and will be available on the Lake Superior Quinn and Great Plains Quinn websites in about 2 weeks. Our webinar series on the opioid epidemic will continue in April with the Area Agency on Aging's presentation on understanding how older adults are impacted by the opioid epidemic. Then in May, the Michigan Licensing and Regulatory Agency will present on the Prescription Drug Monitoring Program and the latest enacted legislation and regulations. Save the dates for these webinars will be out soon. Thank you all for participating and have a great afternoon.
Ladies and gentlemen, you may disconnect your line at this time.